to the NDRI symposium that's listed on the screen there. That's going to be held on the 6th of October in the Perth Exhibition Centre and online. It's going to be a terrific program. It butts against the NADA conference, and I'd be encouraging as many people as possible to attend what will be a great event. Thanks for joining. My name is Paul Dietze. I was just thinking about it, and I've been at the National Drug Research Institute for about a year now. I head up the Melbourne office, and I'll be talking to you about today about preventing opioid overdose, focusing on some sort of local things that we've got going here in Australia, and even more locally here in Victoria and Melbourne, through to some of the international initiatives that I've been involved in. So that's what I was talking from the global to the local and so on. Just to give you a sense of the NDRI office in Melbourne. So basically, I've come on board, as I said, about a year ago to re-establish the footprint of NDRI in the eastern states. Our main remit is to build strong links with collaborators and researchers across institutions and build stronger relationships and partnerships with government and the non-government sector. We're based at the Burnett Institute building there that you can see, and from there I'd like to acknowledge that I'm on Boonwurrung land, and that land's never been ceded, and acknowledge elders past, present and emerging here in Commercial Road in Melbourne. So and also, before I begin, I should give some disclosures in that I've received some investigator-driven from Gilead, investigator-driven funding from Gilead Sciences for work connected to hepatitis C, as well as some funding from Indivior related to the introduction of a buprenorphine naloxone formulation. And I've also been a member of an advisory board for an intranasal naloxone product. Okay, so moving right on. Most of you will be pretty aware that opioid overdose is a major public health issue. It's not quite at the same public health emergency or crisis level that it is in North America, but it certainly is a major public health issue in Australia, and certainly there is evidence to show that opioid overdose runs at a similar kind of rate to our road tolls in many of the jurisdictions across the country. And the key thing about opioid overdoses is that they are preventable. And what are the sorts of interventions that are available? Well, in Australia at least, we have drug and other treatment options. So we have opioid agonist therapy like methadone and buprenorphine, both of which are shown to be protective against opioid overdose, and I'll come back to that in a minute. We also have fantastic first responders, in particular ambulance and fire brigade. They provide direct response through administering the opioid antidote naloxone. And we also have discretionary law enforcement, which does play a role in relation to opioid overdose prevention. We also do education in overdose recognition and response, and that's managed through a variety of different mechanisms, which I'll come back to talk about as we're going along. We also do take-home naloxone nowadays. We have a number of supervised injecting facilities. We also have some specialised primary care centres for key populations in some of our states and territories. And I guess the context is that we have universal healthcare, harm reduction, and other initiatives. And a lot of that harm reduction work is in relation to bloodborne viral infections. And we are sort of switching to focus more and more on opioid overdose prevention. And so I'm going to talk about a little bit about drug and other treatment options, and then supervised injecting facilities and take-home naloxone in today's talk. But I just want to introduce quickly some of the underpinning work which relies upon cohort studies, and I really want to emphasise the importance of cohort studies. We've had a tradition in Australia of funding some cohort studies in this area of illicit drug use and related harms, but the reality is they're pretty hard to fund and hard to maintain, and we have this history of starting them and then not continuing them, which is less than ideal, because part of the idea of a cohort study is, of course, to follow people over time. And the fundamental component of a cohort study is you start with a sample, and then you can look at what impacts different exposures have on different outcomes. And so, you know, if we take, for example, the cohort that I'll be referring to today, which is the supermix cohort of people who inject drugs, it's around about 1,300 people. And we look at whether or not they're exposed to things like opioid agonist therapy, methadone, buprenorphine in this case, supervised injecting facility use, versus those who don't engage in those health services, and then look at what the outcome profile is. Say, for example, a non-fatal overdose. So how many of the people who are exposed experience a non-fatal overdose versus those who don't experience a non-fatal overdose, and compare that against those who are unexposed. So that's the fundamental of the cohort studies along in some of the things that I'll be talking about today. And I'm not going to talk much about opioid agonist therapy because there's other people who are much better qualified than me to speak about it, but our supermix cohort basically reinforced all of the consistent evidence that there is about the importance of opioid agonist therapy as an overdose prevention initiative. And what we've shown in the study that's under review at the moment is that non-fatal opioid overdose is reduced by about 50%. The incidence thereof is reduced by about 50% in people who engage in opioid agonist therapy. And so it's, again, reiterating that fundamental impact that it has. But the main things I want to talk about today, as I indicated, are supervised injecting facilities and take-home naloxone. We have supervised injecting facilities in Australia now, and these are a strategy that are aimed at street-based or public injecting drug use. And as written up there, it's basically these are legally sanctioned indoor facilities with supervision where drugs procured by the consumers from outside the facility are consumed in the facility. It's often in the media confused with heroin prescription and other types of opioid agonist therapy. In actual fact, people have to bring in drugs that are consumed, procured from outside the facility. And they do provide a referral point for appropriate services. Sydney established the first one in 2001 in the English-speaking world. It was extremely controversial at its opening, but really in Sydney it has sort of faded into the background a lot, and people kind of accept that it's there in King's Cross. The history, though, is that there's many outside of the English-speaking world, and so they really originated in Europe in the first instance, in connection largely to issues around public amenity connected with street-based or public injecting drug use. And the evaluation findings in relation to the Sydney one in particular, again referring to the local issues first, are essentially these. There's no increase in drug use or honeypot effect associated with the facility. It ended up reducing ambulance call-outs in the local area. There's estimates that are reduced deaths due to overdose, increasing referrals for clients. There's clear cost effectiveness, and importantly, in the Sydney context, a reduction in public injecting and associated equipment being inappropriately discarded. And so when you have those kinds of positive findings in relation to a medical intervention, you usually think that you'll then end up scaling up and implementing these things more widely. That's what happens in most medical treatments that are shown to be successful and so on. But in actual fact, it's taken us a long time before we were actually able to establish another one in Australia. And as people may have heard, the Melbourne Supervised Injecting Room is the second that's been established in the country. It opened in June 2018, and it was largely in response to some advocacy that came in relation to a coroner's recommendation earlier, as well as some significant advocacy and legwork done by community organisations and even people in the media and people in some parts of the media who you wouldn't normally associate with, who would be recommending the establishment of the facility. It was initially housed in a room in the North Richmond Community Health Centre, which I'll show you shortly. And then there was a purpose-built facility that was completed, I think, about a year into its operation. Ultimately, it was reviewed by a panel of esteemed Victorians, and it was assessed against some key aims which were enshrined in legislation. And ultimately, there was multiple approaches to examining progress towards those key aims. And I'll come back to talking about a couple of them that I've been involved in. So the room itself, so this is the North Richmond Community Health Centre. The initial facility was established in this area here of the building, and it's just essentially a community room that was taken over for the facility in its initial phase, while we were awaiting the completion of this facility. So you can see this is quite a large facility. Here are the injecting booths, for example. But there's a whole range of other ancillary services that can be provided in the facility, and that's part of what the room was aimed to do, is to try and provide additional care other than just providing a space for people to inject drugs. And that's the facility there that you can see, essentially adjacent to where it was originally positioned. Inside the room, here are the injecting booths. You can see they're basically, there's some 24 of them. They're numbered in, so people can work out where to go and so forth, but they're basically pretty innocuous kinds of things. So a clean environment in which to inject, where needles and syringes are provided, and needles and syringes are disposed of for the person who happens to choose to inject in them. Then there's a resuscitation space for people who might have experienced some problems, so they might have had an overdose, for example. And that's basically it. The fundamentals of the facility are injecting booths and spaces for people to consult and be resuscitated and so on. The impressive thing about the Melbourne room was its utilisation. So basically, since it opened in July 2018, there's been around about 107 visits. And then through to around about 192 in the old facility. And then, sorry, this is the average number of daily visits. And then when the new facility opened with much greater capacity, not until the middle of 2019, you can see the numbers here up around about the 300 mark, which makes it equivalent to the Insight facility in Vancouver, which is another large facility and reputedly the busiest in the world. The thing that we've been able to demonstrate through our cohort study is looking at the people who actually use the facility versus those who don't. And the cohort study allows us to then say, as we've just had published in the American Journal of Preventive Medicine, that the facility is servicing people who are generally of more kind of experiencing more vulnerabilities or more marginalisation. So we're able to show, for example, and apologies for this convoluted, complicated table, but basically that people who are unemployed were more likely to frequently use the facility, people who are homeless are more likely to frequently use the facility, people who were living alone, people who identified as Aboriginal or Torres Strait Islander, and so on. Incarceration as well. So basically, the facility seems to have been achieving its aim in attracting some of the people who are experiencing more vulnerabilities and marginalisation and so on. So it seems like a really positive outcome. And this is using the Supermix cohort to evaluate its, one of the things that it's aiming to do, which is to attract appropriate people. Then the other thing that we're able to do with the Supermix cohort is look at those who use the facility. So this is basically broken down, the cohort broken down into those who've used the facility for more than 50% of their injections, or those who have used it for less than 50% of their injections, or those who've never visited the injecting room at all. And this is basically a record linkage component of our work. So this is linking to ambulance attendances. So ambulance is the key frontline response to opioid overdose. And you can see basically the people who use the facility, as I said, those who experience the most vulnerability kind of thing, they were the ones who were more likely or showing an increased rate of opioid overdoses attended by ambulance over time, and that was most pronounced in the most recent years of our cohort. And then once the facility opened and they were using the facility, the number of ambulance attendances for that group dropped quite precipitously. For those who weren't using the facility so much, it didn't have such an impact, and those who obviously didn't use the facility, it basically stayed pretty much stable. But there's a clear demonstration of an impact of the facility being opened. And this finding was mirrored in other data sources that were evaluated as part of the review panel's work. And so we saw, for example, that the number of overdoses attended in the within 1 kilometre of the injecting room actually started to decline. Again, probably more impact towards the, after the facility's been open for some time. But nevertheless, there was a pretty clear impact in terms of these outcome measures related to overdose and so on. The findings in relation to public amenity weren't quite so definitive. So basically, the review panel did conclude that they weren't able to show any positive impact of the facility on public amenity. That said, there are clear health benefits associated with the facility, and they need to be reiterated. So we have this local kind of impact. You can see the very local impact of the facility on overdoses within the 1 kilometre radius of the injecting room. And then what sort of impact should then have more widely? Should we be looking at expanding them and so on? And the government of Victoria has decided to expand the number of injecting rooms as a function of this, the positive findings of the injecting room evaluation or review. And it's now mired in significant controversy. So the Herald Sun, which is our tabloid here in Melbourne, is very anti the idea of establishing another room in the central business district of Melbourne. The central business district is where most of the fatalities and non-fatal overdoses have been occurring outside of the North Richmond area, and so it seems to be an appropriate place to put them. And yet it is an incredibly controversial initiative, and the government hasn't actually decided on where it would like to place another facility, but there's been lots of discussion that's going on. And I just want to draw your attention to some issues around that discussion. So this is a little laneway in Melbourne called Hosier Lane, and it is basically here. So Flinders Street is one of the main thoroughfares in Melbourne. Here's Swanston Street, kind of the main shopping street. Flinders Street Station, a famous landmark in the Melbourne Central Business District. Hosier Lane is literally a few hundred metres away from Flinders Street Station here. And in actual fact, Hosier Lane actually already has services for people who inject drugs. So there are a range of services available in the Central Business District of Melbourne, and one of them is actually around the corner here, and it's called Living Room, and it's a primary health centre for people who inject drugs. And so it's partly reflecting the fact that there is diversity of people who visit these areas. So people who inject drugs visit these areas, tourists do, and so forth. Hosier Lane is a tourist attraction that people often go to, and yet the idea of placing the facility in this building here, which is just only a couple of hundred metres away on Flinders Street, has created an incredible amount of controversy in Melbourne and lots of media debate, which I haven't shown in this seminar. But basically, this idea of expanding from the local findings in North Richmond to other parts of the city is kind of mired in a stagnant debate, and that reflects attitudes and a debate that's really about 20 years old, instead of thinking through, well, how do we make this essentially fade into the background, like what's happened in Sydney, in the injecting room in Sydney that I mentioned earlier. So now I want to turn attention to another overdose prevention initiative, which I think is a really good example of how we've done well locally in Australia over the past few years, but there's an awful way to go globally, awful long way to go globally. So I want to talk about take-home naloxone. As I said, we've come a long, long way. Take-home naloxone was first mooted in Melbourne in 1992 at a harm reduction conference by Professor Sir John Strang. And there's been various initiatives around trying to establish take-home naloxone between 92 and 2012 when it finally started. There was a feasibility study conducted by NDRI that concluded the national trial was needed, but then we had the end of the heroin glut of the late 1990s, and basically opioid overdose kind of fell off the radar to a large extent, and some funding that was allocated toward developing an intranasal option for naloxone administration that I was involved in, but kind of lost focus on take-home naloxone. And in 2009, some publications and some really good advocacy from some community-based organisations led to basically the idea that we no longer needed a controlled trial, and ultimately we could move towards a rollout. And the rollout has had some significant success. And I want to draw attention to an infographic that Penny Hill and Ash Stewart manage that is on the CREDO website, the Centre for Research Excellence into Injecting Drug Use. And the infographic contains all of this information about where the state of play is in relation to take-home naloxone in Australia. And it's a really neat way of summarising the sorts of programs that are available and show the contrast between the different jurisdictions. And here's the actual infographic updated most recently in June of 2021. And you can see from 2012, we have made huge advances in terms of, opening up take-home naloxone in the country. So in all states and territories, we do now have some kind of take-home naloxone program of some description, and the products are available now over the counter. We have a Commonwealth pilot that is being implemented in New South Wales, South Australia and Western Australia. We have peer training in most jurisdictions and so on. And I think this really neatly summarises, though, that there's some pretty big gaps too. So we have exclusion of Good Samaritan protection for intoxication in only one jurisdiction and so forth. We have limited distribution upon prison release, really only in New South Wales, and WA is it done substantially at the moment. But there are some really exciting developments, particularly in Western Australia, where there is trials going on of naloxone being carried by police and paramedics and so forth. So there's lots of activity that's happened in Australia, and it's partly been done in the context of international moves in this regard. And so the global kind of picture that I want to get to now, which is really underpinned by some fantastic work that's taken place at the WHO and the United Nations Office on Drugs and Crime. And this document, the community management of opioid overdose, has really underpinned a lot of the programmatic work, and it makes a number of recommendations, and essentially it's supportive of the idea of take-home naloxone. And it came out in 2014, and as I said, underpins a lot of the work that's going on internationally. But realistically, the number of countries that have implemented take-home naloxone is very small. So even though these data are very old, from 2014, basically we really didn't have a good picture on what was happening in relation to naloxone at all. Very few countries had any kind of naloxone distribution program running at that time. These things have improved at some point, but there is still very limited take-home naloxone available across the world. So, in response, in part that reflects things like the cost and affordability, and accessibility, whether it's available over the counter and so on. But a lot of it really does come down to the stigma and discrimination that people who are at risk of opioid overdose experience. And also fear of legal reprisals in some jurisdictions in particular. And that's neatly summarised in a paper by, again, Professor John Strang and others in 2019. And so in response to this, the international organisations that I mentioned, the WHO and UNODC, have been working together under the Stop Overdose Safely initiative. And one component of that has been a multi-site study involving implementation of the community management of opioid overdose protocols. And the aim is listed up here. So we're essentially looking at the feasibility and impact of community management of opioid overdose. And we're focusing on people who are likely to witness an opioid overdose, which obviously makes sense. And fundamentally, it relates to the initiative more broadly, where the idea, borrowing from infectious disease policy and targets, the idea is essentially to have a 90-90-90 target. So 90% of people who are in relevant target groups will receive training in overdose risk and management. 90% will be given a supply, and then 90% of them who have been given a supply will carry it with them or have it close to hand. So they've given essentially a 90-90-90 target, which is similar to what's applied in relation to HIV and so on. In order to try and provide essentially infrastructure for countries to develop take-home naloxone programs that will be related to those targets, as I said, the WHO and UNODC created that the SOS project itself. And this is the outline of the project here. It's been running since 2016, and there was an assessment phase, a preparatory phase. I'm going to be talking about the implementation phase and the evaluation phase that is essentially ongoing. The implementation phase is based on a very complicated theory of change that I won't go into in detail, but it is available in various reports from it. But it fundamentally is related to a training cascade where the training provider will train a series of master trainers who then go into in turn train other trainers who undertake the fundamental task of training people who are likely to witness an overdose. And this sort of train the trainer kind of model has been developed, and the plan of the SOS initiative itself, the SOS project itself, was to train 15,000 potential witnesses of opioid overdose in a rapid, short-term scale up in 4 key countries, so 3 Central Asian countries: Kyrgyzstan, Kazakhstan, Tajikistan, and then Ukraine. The kit that's being distributed as a part of this is fundamentally designed to be accessible and cheap. So it's simple. It's not intranasal naloxone, which is generally more expensive. It comprises 2 naloxone ampules of 400 micrograms, needles and syringes for intramuscular administration, some basic instructions, and so on. And it comes in a small, very simple plastic kit that can then be used to aid in disposing of any used equipment. So I now want to talk a little bit about the evaluation phase here. So again, focusing on the idea that we've got this initiative that's sort of suggesting that we should be doing take-home naloxone. We've developed up a program in this SOS project, and then the idea is to see how rapid scale-up of this initiative actually goes. And so ultimately we're testing this feasibility of take-home naloxone training and its effectiveness. The methodology that we employed in relation to this is listed here. So there's process evaluation, just about how well we did trying to get those 15,000 people trained. And then there's some focus groups of people who were trained, some key informant interviews. And we're looking at training data, and then an observational cohort study that was fundamentally designed to look at, of the people who were given take-home naloxone, did 90% of them actually administer naloxone at any witnessed overdoses that they might have seen. So how did we go? Well, in what was an incredibly short period of time, we trained some 14,000 witnesses, distribution across the different countries. You can see over 16,000 naloxone kits were distributed, 1,300 or so refills, and this occurred in a period of essentially less than a year, which is a pretty impressive rollout given the logistical issues that go with it, and it just testament to the national research partners who were involved with. So now turning to the qualitative findings just quickly. Basically, there was an awful lot of focus group discussions and interviews, as I mentioned. Some of them were done immediately post the intervention, and others were sort of basically done a considerable period afterwards. And ultimately, we're trying to look at how the knowledge was basically disseminated and taken up, whether or not the project itself impacted on people's lives, any ideas about barriers and enablers, and future ideas and recommendations for upscaling naloxone. You can see there was an awful lot of people who did take part in this. Fundamentally, people felt that now they can save a life, and this kind of empowerment that went with the SOS implementation is very similar to what's been seen in other countries, including Australia. And basically, people reflected on the lives that could have been saved in the past as well. And people felt a sense of self-worth that went with it. And I'll leave you to read the quotes there, but basically, people felt that they were properly equipped and trained to respond to overdose. And in many respects, it is important to note that some of the other frontline services that we're really used to in a country like Australia just aren't properly available in these countries. So, when you call an ambulance in Melbourne, you're guaranteed that it'll get there pretty quickly. They're sometimes criticised, but paramedics do an incredible job in Australia. But in some of these countries, the paramedic response just isn't there. And the paramedics might get there and they might not have naloxone. You might get taken to an emergency department where there's no naloxone either. And then there's also this idea that basically the people themselves were taking a lot of strength from it as well. So they were responding to the messages about not injecting alone or using less frequently and so forth, checking drug quality and so forth. And some of them even stopped using drugs altogether. And you can see there's also this trust that went with the engagement that came with this measure. So people felt more comfortable with the healthcare providers they work with and so forth. And even in some instances, there's more trust in some police. And, that's a really positive outcome in terms of trying to ensure that these programs are effective in what can be challenging environments. And you can see, some of those quotes reflecting those kind of sentiments. And then also just this idea that there's increased acceptance or positive community views about people who use drugs, and people feeling more valued and important, as well as empowered, as I indicated previously. I'll leave you to read the quotes. Okay, so now I do want to acknowledge Shelley Walker's contribution in pulling together the qualitative findings here. I'll give full acknowledgements of everybody at the end, but my main focus has been on the prospective cohort study that I mentioned. And fundamentally, there's many questions that we can ask of this cohort study, but the one that the two that I'll be considering today are whether or not training implemented using the protocol actually improves knowledge about overdose and overdose response. And then, as I said, whether or not 90% of trainees use naloxone at any witnessed overdoses. And fundamentally, the design of the cohort study was similar to many of the other studies that have been conducted in this domain. So people were recruited into the study, baselined, where a number of different measures were taken, such as the brief opioid overdose knowledge scale and the opioid overdose awareness scale, and so on. And then they were provided with training and given naloxone at the end of the training. And then we administered some of those same questionnaires again, see whether or not knowledge had improved as a result of the training. And then at 6 months, we recruited again. People who were recruited in the cohort were interviewed again to see whether or not they'd experienced any overdoses themselves, but most importantly for today, whether or not they'd witnessed any. And if they did witness any, whether or not they'd used naloxone. And the idea was not to recruit all 14,000 people who'd been given naloxone as part of the SOS project. Instead, we selected a sample. The idea was to have 400 people from each of the 4 countries. And we did remarkably well at getting 1,600 people. And again, I want to reiterate what a short period of time this was. Characteristics of people. So obviously not all people who are participating in the SOS training are people who use drugs. And so we delineated between people who use drugs and people who didn't identify as such. And you can see there are some differences. So for the people who use the people who use drugs who were in the cohort, most of them were male, whereas the distribution between males and females was more similar in people who didn't identify as using drugs. Employment status and so forth was a little different as well. So turning now to whether or not the training itself had an impact on knowledge and so forth. So these are the baseline scores. I won't go into the detail about what the scores actually show, but in essence, they show reasonably high levels of knowledge across both groups, slightly higher amongst the group of people who use drugs, and that sort of emphasises again the importance of getting people who use drugs involved in their own healthcare and overdose prevention and so forth. And you can see 93% of them said they'd ever witnessed an overdose, compared to 66% of people who hadn't. You can see rates of ambulance call out are very low compared to Australia. So the figure for Sydney in the 1990s was something like 56%, and in Melbourne in the early 2000s, around about 78%. So that shows you the contrast there. And what we did show, though, even with these these are relatively high numbers on these scales, even with these relatively high numbers, we did find improvements in their responses as a result of training. So this is the questionnaires taken again directly after training. You can see in almost all instances there were significant improvements in knowledge, competence for responding to overdose, and so on. There was a slight decrease in relation to readiness, which comes as a bit of a surprise, but not, I can't really explain exactly how that came about. Then the fundamental thing, though, really is whether or not people are going to use naloxone at the overdoses that they witnessed. And here's the findings in relation to the 6-month data that we collected. So around about 34% had witnessed an overdose since baseline, so in the last 6 months. So that's pretty extraordinarily high. It's much higher than, say, in our Supervised cohort. And of those people who did witness an overdose, 90% of them, just under 90% of them, reported they had used naloxone at their most recent witnessed overdose, which is in essence what the program is trying to achieve. It's not exactly the 90-90-90 measure that I was talking about earlier in relation to the SOS initiative, but the SOS initiative is being modified to include this, that 90% of people actually used naloxone at witnessed overdoses. In almost all instances, the victim survived. Where it wasn't clear, it just wasn't clear. It wasn't necessarily that they passed away. And there's other program variables which I won't go into that are also really positive as well. So ultimately, the SOS project has shown at a global level across these 4 countries that take-home naloxone using this protocol can be implemented at scale. It can work to improve responses by overdose witnesses. It can also improve their knowledge pretty clearly as well. And people who do participate in the program use naloxone at the witnessed overdoses. And that's in line with the expected targets that we have. So this is a really positive story at the UN ODC and WHO level, because this kind of demonstration highlights how the relatively simple protocol that's been developed through the SOS initiative can actually be scaled up at relatively low cost and really quickly. So again, I want to emphasise that this scale up occurred in a relatively short period of time of some 6 to 8 months in each country, which is incredibly impressive. So in relation to the further plans to do wider dissemination and so on, fundamentally it's all about now supporting sustainability and scaling up of programs, and then advocacy and promotion in other countries where take-home naloxone isn't necessarily implemented yet. And the WHO and UNODC are working hard now to integrate opioid overdose response into their technical packages and initiatives, and that relates to things like medication, opioid agonist therapy, and so forth. But of course, these things aren't going to solve the problem of opioid overdose globally. So, as I said, urgent scale up is needed. The 2014 figures on the number of countries with access to naloxone were pessimistic, and they have only improved a little bit since then. But we also need to upscale all overdose prevention interventions, and that includes opioid agonist therapy and so on. And a lot of the initiatives that we have at the moment don't really cover off people who use alone or consume in the home and so on, and can't be found by a witness to implement take-home naloxone and so on. And a lot of our focus is on deaths among people who don't inject drugs. And opioids aren't necessarily that widely available in countries outside of Western countries, but there is still a significant proportion of people dying of opioid overdose amongst people who don't inject drugs, and we need to be focusing a lot more on those efforts. And with that, I'll pass over to questions and just make clear acknowledgements of all of the people who have been involved in all of these studies. In particular, I want to draw attention to Penny and Ash, who were involved in managing the National Naloxone Reference Group, and Anya Busse and Dmitry Krupchanka, who were from the UNODC and WHO, who've been instrumental in implementing the SOS initiative internationally. So